Hey everybody, welcome to this week's installment of the Ultrasound Lecture Series, Airport Edition. So I am currently meandering through Cleveland Hopkins International Airport with my ultrasound mask, headed down to Phoenix to get out of the clouds and also learn how to do a little TEE. I'm pretty stoked about that. What I'm even more stoked about is to have Laura Brown presenting to us today. You all know Laura. She's one of our trauma surgeons. She's one of the ultrasound aficionados from the trauma side. And I've asked her to come talk to us and give her perspective on ultrasound. And she gave me two great topics. So she's going to come back. But today we've chosen to ever talk about basically how to use ultrasound to guide fluid resuscitation in the trauma patient and critical care patients. So I'm pretty stoked about this. I'm going to have to bug out here in a little bit to board my plane, but I'll certainly be watching on the replay. But Laura, go ahead and take it away for us.
Okay, everyone, I'm going to share my screen. Give me just a second. We'll bring it up. Hi, everybody. Hope you can see me. I'm going to just bring everything over so I can see you okay. Well, everyone, I really want to thank you for the chance to talk with you today. And again, I am going to give you the critical care intensivist version of ultrasound. I wanted to kind of focus on this a little bit because we've been talking about the study that we did last year and how important it is to use ultrasound kind of as a daily, minute-by-minute tool in the ICU to help figure out what your patient's volume status is. I mean, volume status is the age-old question in the ICU. Have you given too much? Have you given too little? Is that why they're still on vasopressor? Or what's the reason? And I feel like it is such a critical tool. I just came from rounds today, pulled out the ultrasound on multiple people to decide, do we need to titrate down our fluids? Are we still behind in our resuscitation? What do we need to give? And so, and I think it's also important that, you know, as an intensivist, especially as a trauma surgeon, I can have different types of shock. I can have different types of resuscitations that I'm running. So it might be sepsis in one room and the next room might be hemorrhagic shock and I'm actively running MTP. Or is this more of a cardiogenic shock picture? And it's literally room to room to room. It's different. And it can be really important because you can have, for instance, I had last night or yesterday a septic shock patient who also had right heart failure. So it was a combined type of shock. And I feel like what happens, I think, if you aren't looking at the heart, you miss that information and you're treating septic shock without understanding why the patient's not getting better. So today we're going to focus on POCUS for volume status. And I'm not going to talk about the other methods that we use in the ICU to assess volume status. I'm literally just going to focus on ultrasound. But I wanted you guys to know the evidence behind the kind of screening method that I'm going to propose to you. Now, there are lots of different screening pathways or screening techniques that have been described. There's the RUSH method, the FATE method. This is specifically a protocol that we wrote for our study last year that is focused on assessing volume status. And so I'll walk you through that protocol. And I'm happy to send those slides to you separately and the data that we collected, the data that we used for the study. I want you to really, as we're doing this, keep in mind that it's not important what last week's echo was. It gives you a baseline or a background, but because the patient's physiology can change so quickly in the ICU, you really need to use POCUS regularly to reassess where you are and reassess how your patient is tolerating the resuscitation. So it's really important to get in the habit of getting that ultrasound out on rounds, giving a little bit of fluid, reassessing. I had my fellow last night was actually literally standing there at the bedside with the ultrasound as we were titrating vasopressors and titrating the resuscitation. So I am a big proponent of focused echo, and that's, you're going to see very basic windows, but focused echo longitudinally and using it dynamically to help you resuscitate. So that's the focus of today's talk. So let's just really quickly, I'm going to describe this method for you. I want you by the end of the talk to be able to compare the different methods of volume assessment by POCUS. And most importantly, to be able to differentiate between static methods and dynamic methods. Each of these methods, each of these techniques is part of the protocol, but I want you to understand which ones you can rely on and which ones will not really tell you whether the patient is fluid responsive. So it's really important to me that you know the evidence behind the measures. And you also need to remember that these methods differ, or the values that you use differ based on whether the patient is mechanically vented or a spontaneously breathing patient. We're going to discuss approach to a couple clinical scenarios, but if you follow me up to the ICU for the scanning day, we'll talk a little bit about how that applies to real patients there. So we can spend more time on complex cases in the future if you're interested, and we can even do a couple real-time resuscitations where I have the videos and we can talk about what we give and what decisions we made. So let's talk now about fluid responsiveness. So for those of us who are ICU-based, critical care-based, we decide that a patient is fluid responsive if they have more than a 15% increase in cardiac output with a fluid bolus. So people feel very differently about CVP depending on where you train. I will say that there are a lot of people who no longer use CVP. This is a very old study published in, it's actually based on a figure from Shippey in 1984 that measured more than 1,500 different CVP measurements. And as you can see on the y-axis is the CVP measurement and the volume is on the x-axis, and you can see there's literally no correlation between the two values. And so if you're going to use CVP, I need you to know whether or not you rely on it, whether it was measured correctly, how do you measure CVP, what affects the way that you measure CVP, but that's not today's talk. I think it's really important to remember that there's, and this paper, this chest paper from 2008 goes into a lot of detail about the poor relationship between blood volume and CVP. It's a systematic review of those 24 studies with more than 800 patients, saying that the correlation between CVP and volume is less than 0.12 or 0.16. And even the stroke index, so the corrected cardiac output stroke index was not related at all to your CVP measurement. So what other methods do we use to monitor fluid status in these patients? So in the general surgery boards, and this is really important for my general surgery residents who are listening and for the critical care fellows, this is a big part of our boards. They actually ask you, it's not just on your written boards, but also on your oral boards. They'll give you a scenario and ask you what numbers you're going to use to decide whether the patient's fluid responsive. So arterial waveform, positive pressure variation. And that's in this back circle here. Hold on, I got to get my marking pen here so that I can show you. This back circle right here describes a little bit about that, how that's done. Essentially, you're using an arterial tracing and you're looking for variation in the pressure based on respiratory cycle. So as the patient is inspiring, you'll see a difference in the venous return to the heart. And if the patient is fluid responsive, there will be a difference in the pressure correspondingly. Now, delta or a positive pressure variation of 12% is suggestive that the patient will be fluid responsive. There's some limitations to this method, and this is where the questions come in. A patient must be in sinus rhythm. They have to be mechanically ventilated at greater than 8 cc's per kilo, which almost never happens in this day and age in the ICU. And so you have to be careful of that. The other one that can happen, and this burned us in a trauma patient recently, where somebody told me that they didn't think the patient was volume responsive, but they forgot that the patient had an open chest. So it requires an open chest in order to get accurate measurements, in order to get the appropriate delta. The other methods that we talk about big in the critical care world are non-invasive cardiac output monitoring. Those are like flow track, Visualeo. There are pictures of those here. I will tell you that the nurses are not a big fan of these because it's extra measurements that they have to take for the Cheetah, for the NICOM. That's based on bioreactants. The flow track and the Visualeo, our cardiac patients come up from the OR on the flow track. And I think it's easier to kind of interpret it. I think the numbers are a little bit more intuitive. They have cute diagrams that kind of explain to you what numbers are going up, what numbers are going down. What that doesn't tell you, though, and it's less helpful, is if the patient is fluid responsive, unless you're giving the bolus at the time and you can see whether or not they're responding positively to it and cardiac output is going up. Because that's really the question. If you really want to know if the patient is fluid responsive, you're going to give a bolus and see if your stroke volume goes up. Now, the advantage of a passive leg raise maneuver, as opposed to just giving the fluid, is that you can give a temporary bolus from the legs, and you can take it back if it doesn't work, or if it hurts the heart, or if it makes things worse, right? And the problem is that if you just give fluid challenge after fluid challenge to see if the patient's fluid responsive, you're going to give many boluses, and it may or may not be helping you. So The other technique that's used a lot right now, and it shows up on the boards, and this is why I bring it up, is the idea of an expiratory pause. So it increases the intrathoracic pressure, which gives you a temporary bolus, but you can also take that away. We can talk more about that at another time, but I wanted you to remember that because it does show up on your board. So make sure you talk to me if you don't know the answer to that question. Well, how do you perform that and what number would matter? I will say there's some limitations to each of these methods. So we talked about the limitation with positive pressure variation. We talked a little bit about NICOM and limitations. One of the issues with a passive leg raise that we ran into in our study is that patients with spinal fractures, obviously you're not moving them up to 45 degrees, a little bit harder to do with an open abdomen that's being held together with a piece of IABAN. I will say that, passive leg raise was definitely kind of first really promulgated in the Pro et al. Article from like 2010s, demonstrating that you could determine whether a patient was still fluid responsive in the setting of sepsis and acute pancreatitis. So, that delta pressure of greater than 9% in a passive leg raise would tell you that that patient would be fluid responsive. Not really practical, as I said, in trauma patients or in patients in hemorrhagic shock. So, okay, so then let's talk a little bit about why this matters, what fluid responsiveness means. I just need a little bit of background. You guys are probably know this, your cardiac physiology, this will all sound familiar to you. If not, we're just warming up. So this is the Frank-Starling curve. Everybody remembers this, right? So if you look at the curve on the left-hand side, this is your preload. Hold on, where am I? I'm having mouse difficulties. This is your preload curve on the left-hand side, preload on the x-axis, stroke volume on the left axis. As you increase the amount, as the patient is more and more responsive, in the beginning, when you have a small increase in preload, you get a big increase in stroke volume. And then as the patient is more and more resuscitated or at their volume or slightly more, an increase in preload doesn't actually help the heart squeeze better. The heart reaches its maximum. Then this line number 1 is normal contractility. If the heart doesn't squeeze very well, then you see less of a response to each amount of preload. And then if you can imagine in a very poorly contracting heart, you would get actually very little response to any increase in preload. So this is just file this away to remember that your squeeze is important, as is the ability of the ventricle to relax. So that hydrostatic pressure that's related to how well the ventricle relaxes during the fluid bolus. So again, here's your left ventricle volume as it's increasing, and this is the left ventricle pressure on the y-axis. So as in a normal heart, you'll see normal left ventricular compliance, so that as the volume increases, the pressure very slowly increases in the beginning until you meet your fullness or capacity, and then you see a much higher increase in pressure for a small amount of volume. And you can imagine in a heart that's got some diastolic heart failure, hypertrophy, that the volume will be less well tolerated, and you'll have higher increases in pressure as you're giving your boluses, as you're reaching that volume. So the ability of the heart to both contract or squeeze and the ability of the heart to relax are absolutely critical in how each patient responds to fluid. So when you look at these numbers and when you look at these studies, you have to be careful, because these studies are done on a wide patient population, and each person's contractility and compliance is different. And so the numbers that apply to your patient may or may not fit into that parameter from the study that was done. But it's also important to remember that the most accurate way for you to see how well your patient is tolerating that bolus or tolerating that volume that you're giving, or might be volume responsive, is based on the way your patient's heart responds during the study. And so that's why it's important for you to put on the probe and take a look. Not all fluid is benign, and not every heart responds the same. So let's move on to just kind of a clinical scenario. You have a patient who presents to the ED or to the ICU in severe hypotension. What's the first thing you want to do, in terms of determining where that hypotension is coming from? Let's say you think that it's a perforated viscus and the patient's got septic shock. And your question then is, what do I need to do? Well, you're going to give your 30 cc per kilo bolus. Patient responds a little bit to that, but now still very hypotensive, systolic still in the 80s. And you're thinking, okay, well, the question is, what do I do now? Do I give more fluid? Am I resuscitated enough? Does a patient need more volume? And so I would say at this point, you need to use your tools, right? So this is probably the most common place where junior residents and our younger trainees may struggle because they're going to follow a protocol, right? They have a protocol. Surviving sepsis is give more fluid, right? Put the probe on. Look and see how your heart's responding. So let's just go through each of the pathways. In the setting, you put the probe on and there's suspicion for right ventricular failure, you're going to follow a slightly different pathway. If you're the first question, and I think these two red boxes on the right are the most important, is the heart compromised in its function and why? That's the key here. That's the key question is your heart compromised? Because that's going to change how your patient responds to fluid going forward. And we're going to talk a little bit about how you use these tools to quickly differentiate. If the heart's not compromised and it's low cardiac output, then you probably need some additional fluid. If the heart's not compromised and it's high cardiac output setting, right, the patient may just need some vasopressors, right? So the heart's tolerating this well, it's doing what it's supposed to, and you probably just have low systemic vascular resistance and need some medication to help you manage that, right? Some vasopressor to manage that. So let's go back to the middle column here, the heart compromise. And this first kind of screening zone is where I want the junior residents and trainees that you need to get fast at kind of differentiating between these two. Ideally, this exam should take no more than 5 to 10 minutes for you to put a probe on, take a quick look. It's the equivalent of carrying your stethoscope in your pocket. So let's talk about, we're going to focus on this step right here, the star in purple here, and we'll come back to this diagram. We're going to walk through it step by step. So first thing you're going to do is put the probe on. I'm going to go through the basic windows just for the most junior folks who are on. You probably already know this. Diane has the right to step in and correct me or give feedback or say anything at any point, Diane. So please don't hesitate. I love you and I love your input. So first thing I want to say is positioning the patient is key. In the ICU, the patient is turned Q2 hours. So it happens every single time that I'm going to see my patient that I got them on the right side down turn. So the first thing I end up having to do is reposition my patient, put them on the left side down, right? So that I hopefully bring the heart closer to the anterior wall, and I'm going to switch to cardiac mode using whatever probe. I'm not going to go into the details of each of the settings. This is something that we can kind of work on at the bedside. We're going to start with a parasternal long axis view. That's where we essentially are going to come right. You're going to turn the probe with the indicator to the patient's opposite shoulder. So indicator here to the patient's right shoulder. And you're going to start at the maneuvering clavicle, slide down till you see a flash. I teach it this way because this is how I teach microscopy, which is that you have to get into the right plane first. So, and this is why I have set up this screening method. It's the fastest that I have found to teach novice people who have never done this before and who have struggled to try and find the heart in the chest. So you're going to, as soon as you see that flash, you're going to try and isolate the mitral valve into the center of the screen. So let's just focus on what the typical view would look like, plus or minus a little bit, and what chambers are visible to you. So always the right ventricle in this view is anterior closest to the probe here. And then you're going to have your left atrium in the lower corner here, left ventricle in this direction here. You see this dotted blue line. Now, ideally, I'm not going to see the entire ventricle, or I may have foreshortened it, or I may not be in the most optimal view to see the mitral valve. I really want to try and isolate the mitral valve in the center line here. Coming out of the left ventricle, then will be the aortic outflow tract. So what are the things that we look for in this viewpoint very quickly that I'm teaching someone, a novice person, to look for? First is, does the heart look like it's squeezing good? Right? And that squeezing good, what do I mean by that? I mean, is this mitral annulus moving? When I explain this to trainees, I say it's more like a mop ringing than anything else. So when we talk to people, we kind of do like this motion, right? Like a fish mouth closing, but that's not how the heart works. It's more like that mop ring where it's squeezing and pushing up at each turn. That's based on the arrangement of the fibers in the myocardium. So that motion is called mitral annular plane systolic excursion. And that is a very important measure. We're going to talk a lot about that in the data behind this, but you can see it very easily in this view because you're going to see this entire motion go back and forth as the heart moves, or you may not see it move at all. And so what we know is that this is actually a very easy measurement for even a novice to see, because if they've seen even 1 or 2 echoes where the heart's moving and there's good MAPSI, then they recognize that motion. And then if they don't see it, they recognize it right away. Okay. The last thing I want you to notice from this view is whether or not this aortic outflow is narrowed. That's really what I'm looking for. Occasionally you'll see some other points like the right ventricle is bowing in a little bit here. You may actually be able to see a pericardial effusion. Now this is not an ideal view, and the reason why I say that is because you can't see the aorta coming down, the descending aorta here, which would be ideal if you were actually looking for the pericardial effusion. But this is, again, it's a screening method, fast screening method. So the two things that you're looking for in this window is the MAPC and the aortic outflow tract. So why MAPC? Why does that matter? MAPC is measured by the untrained observer, can help you predict the ejection fraction of the left ventricle. Now, I will tell you the sonographers who are well trained are much better at measuring ejection fraction than probably any of us are going to be. And that's why it's better to have a quick and easy measurement, something that you can rely on that is fairly predictive of what that ejection fraction is going to be. So remember, to measure ejection fraction, you could get the 4-chamber view, you do Simpson's biplane method, you could, essentially look for the cylinders in the heart, count them up and calculate the area. That's obviously going to be much above a 5 or 10 minute excursion, right? Because we got to do this fast. We're resuscitating a patient quickly at the bedside. So this is a retrospective study, this one that's demonstrated here in the Journal of American Society of Echocardiography. It was 600 2D echoes using the M mode in an apical 4-chamber. And I realize that's not the view I just showed you, but hear me out. I'll explain why it matters here. There was no specific optimization of the windows. And the average image quality was fair to good, somewhere between a 2.8 out on a Likert scale of 4. So not medium and not great, but somewhere between the two. They drew an M line through the medial and lateral annulus and then calculated the mitral or annular plane systolic excursion. The peak is your max systolic and the trough is the diastolic. So if you look at this M mode is a mode that allows you to draw a line through here and watch the planes of signal coming back at you in that line. So it'll draw a longitudinal line that correlates with the cardiac cycle that you can see down in this lower area, in the lower area of the picture here. Pardon me. So peak is your systolic excursion, and then the trough is your diastolic. So it's much easier, right? They use the first 300 of those 2D echoes to calibrate and then used the next 300 to verify in the cohort that it was actually correlated with EF. Now, the person who calculated the EF here was an expert, not a novice. So the novices measure the MAPC, but the expert measured the ejection fraction. And it was amazing, given that these were novices. These were literally students, first-year medical students who did the calculations, who measured MAPC, and they actually correlated pretty well. There is some gender difference, obviously. Let's talk just a little bit about the accuracy here. So why this is important to you, that the sensitivity was 73%, specificity was 100% in the setting of severe differences in ejection fraction. So for instance, a very low ejection fraction was actually very, very specific, easy to detect from MAPC. And that was what I was explaining to you. I can literally pick a medical student off the street, not even a medical student. I've had family members be at the bedside with me and be like, hey, that's not moving as good as it was yesterday. So it's actually very, very predictive. And I think that that's important, especially because you can have junior members who really haven't been practicing echo windows, but it allows you to fairly reliably tell whether or not there's a difference in the way that the heart's squeezing. So again, they use that calibration cohort and those calculations to calculate the area under the curve, and you'll see that that's actually a pretty tight ROC. Now, I will say that this is I'm sorry, that's not the area under the curve. This is a new study. I apologize. I got talking too fast. This is another MAPC study. This was published in just a couple years ago, 2018. They collected patients over a year and a half period prior to the whole COVID business. It included sepsis criteria, primarily for sepsis, so that's something you need to remember, and excluded pregnant and people who they couldn't get decent windows in. They screened almost 60 patients. 10 of those were excluded because of those criteria. And they got the echo within 48 hours of arrival, and they used MAPC to predict mortality in those patients. So both MAPC, your E to E prime, and your left ventricular systolic function by Gestalt were significant predictors of mortality. When they did the multivariate logistic regression, MAPC and the Apache score actually achieved an area under the curve of about 0.95. So very highly reliable predictors of mortality. So that's important, because what that tells you is that, one, even a novice can tell what that looks like on your echo, and that it actually is fairly predictive of how well that patient's going to do. So a fairly good prognostic predictor. This has also been shown in pediatrics. In 2018, there was a very similar study done that demonstrated the almost exact same thing in children. So MAPC is a very good predictor. Here's one other recent publication. This is actually, I guess it's not recent anymore. I'm sorry. It's almost about 10 years old. I apologize. 2013. And this was a prospective observational cohort study of, again, about 50 patients who had met SIRS and shock criteria in spite of their fluid resuscitation. So there's that patient again, that septic shock patient who you're trying to decide, have we met our resuscitation goals or not? They got their echo within 12 hours of arrival, and then they got an echo daily for 7 days. The day one results showed a difference in the MAPC that wasn't seen in any of the other measurements that they got. The predicted left ejection fraction, E prime, the troponin, high sensitivity troponin, or BNP, right? So very, very predictive. MAPC was very predictive of the patient status, okay? Okay, so let's look real quick. Here's an odds ratio, the multivariate analysis here for predictors of death. So MAPC was very, very predictive of what their mortality would be in the setting of shock. So what's really important in this study, and what I wanted you to kind of get from this, is these two tables, I think, or these two figures are the best comparison. So this figure on the left here is a box plot of the daily measurement. So on day 1 to day 7 here, okay, this is the measurement of left ejection fraction. These are the white column is the survivors, and the gray column is the non-survivors. Interestingly, you'll see that there's not really a significant difference between survivors and non-survivors going forward through that 7 days, okay? In terms of what ejection fraction was. But interestingly, MAPC was highly predictive, and there was a significant difference between the survivors in white, who had a better MAPC, and the non-survivors who had a lower MAPC. So I think this diagram very clearly shows you that MAPC is, one, easy to measure, or these papers show you that, one, MAPC is easy to measure, and two, that it's actually highly predictive of how someone is going to do in shock. And this was all types of shock. This included hemorrhagic shock and septic shock, so hypovolemic shock. So now, the one caveat to this study that I want you to know is that they measured ejection fraction by the eyeball technique, which was mostly by an expert declaring what they felt that the ejection fraction represented. So, but it was blinded, so hopefully that's a little bit more reassuring. Let's talk about some other things that you can see in this quick scenario. So MAPC is one of your most reliable techniques. Let's move on to another view. So we're going to talk about the parasternal short axis. And please forgive my stick figure diagram, but this is the easiest way for me to show you. You're essentially going to, when you are sitting right there at the mitral valve and you're focused on the mitral valve in the screen, you're going to rotate your probe 90 degrees to the right. So now your indicator is pointing to the patient's left shoulder. You're going to start it, ideally, if you're on the mitral valve and you've oriented yourself correctly, you'll start with this fish mouth view, which is right here. So the yellow dotted line indicates the left ventricle. And then this is the mitral valve here. Now, if you tilt the probe up, so you're going to drop your hand here, tilt up and look up in this direction, you're going to see the aortic valve. Ideally, it's a tricuspid valve here. This is a picture of that chevron view that you get. Sometimes it can be really hard to see. And then you're going to also tilt the other direction. So you're tilting down. So again, you're going to look this way, right? And tilt down, put the tail of the probe up in the air, and you're going to look down at the papillary muscles. This is where you can try and find your left ventricular and diastolic area. Okay, now this value is not reliable. This is a static measurement. It's basically calculated at the end of the diastolic cycle, at the end of diastole, end of the cardiac cycle, when hopefully the ventricle is as filled as possible, and you would essentially measure out the end diastolic area here and use that number. So the last thing that's really useful about this view is that one of the things that you can do by, again, ultrasound being dynamic, is you can rotate up and down to get an idea of how you think the left ventricle is squeezing. And then this is what I think is the most important or most reliable, especially for novices, is how well does the left ventricle come together around the central point. And sometimes when I'm showing people on the screen, I put my finger right in the middle here and I say, does the wall come around my finger without touching the screen, Diane, don't worry. Does the wall come around my finger, right, reliably from every direction, or is there a regional wall motion abnormality? And if it is, what wall motion problems are we having, and does that potentially correlate with an acute coronary syndrome? So, quick note for advanced users, this is again where it's very reliable, where you can determine if the right atrium right here is potentially in either a high or increased volume or increased pressure zone, whether or not there's what we call the C or D sign here. So this is the right ventricle, right? And if you have a lot of pressure from the right atrium, you may see this septum flatten right here. We had several of those cases upstairs in the last couple of days. Sepsis and right heart failure is really, really hard to manage. And so that actually was a very, one of our trainees picked that up. So I'm glad that you guys are paying attention to that. Let's just talk a little bit about, whether end diastolic area is predictive. So this is based on TEE. So not transthoracic, but transesophageal echocardiography. And they measured the response to 500 cc's of pentastarch. So that already dates the study for you, right? That's got to be at least 20 years old because we don't use pentastarch anymore. We know it's not good, right? This was 20 medical ICU patients and 20 cardiac surgery patients. So what I want to point out to you from this study was that the response, the predictability of end diastolic area to correlate with pulmonary capillary wedge pressure, whether or not that's a good measurement, that's a whole nother Oprah, but that is only predictive of whether or not the will increase wedge pressure. The end diastolic area is is predictive of fluid responsiveness. At the very extremes. And so what I'm going to point out to you is if you look here, the responders are down in this location, right? If you look at the medical patients, you'll notice that it's here, right? So if their end diastolic area is less than 12, then it's potentially predictive of the response to fluid. This is not a reliable technique, in my opinion. I think that this is potentially the limitation of trying to rely on one or two studies that show this. You'll see a lot of people say, well, the ventricle completely collapses during systole. Well, ideally it should. Ideally that ventricle should be squeezing very well. So I want you to be careful about using that as an indicator of volume status, okay? I think there are a couple times when it is useful. There are a couple of situations when it has been a little bit more predictive or been validated. This is an indwelling catheter. So it's a hemodynamic TEE that's used in the burn intensive care unit. So this is an indwelling TEE probe. It's a 19 French, so about the size of a nasogastric tube. Just a warning to you, I have used this. It is really hard to use around a nasogastric tube. So my choices were I could have the NG tube or I could have the TEE, but I probably couldn't have both. But you leave the cath, you can leave the TE probe in, and you can use it continuously for 72 hours, which is ideal for burns because you're resuscitating a patient. And in patients who are burned on the thorax, obviously a TTE is not very reliable. So this is one way for you to assess volume status in burned patients. Because it's such a small scope or such a small interface, it doesn't get as hot as the traditional TEE. So that's why you can leave it in place and use it continuously over that time period. Now what I would typically do is I would put it in place. I get it in place. I do one or two measurements, give the patient a little bit of volume, and then I take it out for a couple hours, kind of see where we are and then reassess. So that may be the one exception that I think that you might consider using end diastolic area as a measure of volume status. But again, it's a limitation also static, because you're not determining whether or not the patient is fluid responsive. It's just the measurement that you get at that time. Let's move on to the next window because I'm running out of time. So this is the apical 4-chamber view. So what I like to teach people, especially novices, is that you come from your mitral valve and you're just going to slide off the end of the ventricle here down towards the corner. This can be harder to do in very skinny patients where the thorax is very firm and there isn't a lot of tissue for you to transduce the signal through. It can be a little bit easier in women who have breast tissue there. The one challenge may be that you need to come right along the inframammary crease right there and kind of transduce up through the breast tissue to get the ideal view. The one warning that I would say about this view is that it's very easy to foreshorten the chambers, and that is not going to give you as good of information. I will say that this is, I think, a little bit more technically challenging for the novice sonographer to get a reliable 4-chamber view. This is the labeling of the 4 chambers, again, in a cardiac view where your indicator's up here on the right-hand side of the screen. I sometimes find that it's easier to teach people the subcostal view. So I do teach people both. The reason we don't use the subcostal view in a lot of general surgery patients, obviously, is because they have abdominal wounds. So that can limit our ability, or open abdomens too, which can limit your ability to see from the subcostal position. Okay. So why this view is important is because if you actually bottom shallow out just a little bit more in this view, you can actually get what's called the 5-chamber view, and you get the, my drawing's not ideal here, but there's the aortic outflow tract comes in this line right here. And that's where you can measure your, where you can do pulse wave Doppler measurements to actually get an idea of how much blood is flowing through that aortic valve at any time. And that is one way that we can measure stroke volume. I find that that's very hard to teach this view specifically and that technique to novice sonographers. So I have stopped trying to do it. Instead, what I ask them to look at on this view is what is the relationship of the right ventricle to the left ventricle. That ratio is actually the one thing that's been validated. If it should be less than 0.6. If it's more than 1.0, if the right ventricle septum is bowing into the left ventricle, that's worrisome for right ventricular heart failure. Again, this is just a quick viewpoint. We're at minute 3 of the quick scan to try and see if what might be causing our hypotension in our patients. So let's just review real quick the methods that we just talked about. These are all focused cardiac views, static. The left ventricular end diastolic area is only useful at the very low extremes. I would caution you against using that. Dynamics measurements would be an ejection fraction eyeball. Again, probably most useful in experts who have seen multiple different echoes and can better predict what that fraction might be, but probably the one that's most useful, especially for novice people, are novice sonographers or MAPC. And we didn't talk about it and how you would measure it, but the tricuspid annular plane systolic excursion. So not the mitral valve, but the tricuspid valve to be able to measure right heart function. These are why I think this is useful. These focus views that we just talked about, you can determine if the left ventricle is hypokinetic, if you've got increased pressure from the right atrium or increased volume in the right ventricle. Whether you've got outflow tract obstruction, if the aortic valve didn't look right to you, either from, a lot of calcium buildup around there. And this is just a quick view. That's all you're looking for. You just want to try and have an idea of where you need to target your information and gathering and why the patient may or may not be responding to fluid. Okay, let's move on. So we've taken care of this star. So up here, so we got our echo, and let's say in our patient that we're resuscitating came in with septic shock, they've gotten the initial volume. We didn't see any aortic outflow obstruction. We didn't see any underlying hypokinesis. The heart is responding well to fluid. It seems hyperdynamic. It looks like probably their patient's still hypovolemic because the heart's squeezing real well pretty fast, and we think maybe this is early sepsis. So we're going to try a fluid bolus. And then again, we need to do this on next fluid bolus. The questions that you have to ask yourself if you're going to use POCUS to kind of reassess where the patient is the patient spontaneously breathing? Do they have low tidal volumes? Is there low lung compliance and irregular rhythm of the heart? All of that may affect how well any of these different measurements, the ones that we're going to talk about right now, the IVC predicts. So if you have a patient who is mechanically ventilated on low tidal volumes, that's going to change which calculations you're going to use. So this is measuring the IVC. Again, this can be really hard in general surgery patients who have open wounds, or some of our trauma patients who have abdominal wounds. You ideally want the patient in the supine method. If you put the patient in the left lateral decubitus, it's going to relieve pressure on the IVC. That's why we do that, right, in pregnant women. So be aware of that, and that may change your view. So you may have to adjust the patient a little bit more. I put phase array or curvilinear. It depends on the depth of your patient in this view. You're going to start subcostally, just lateral to the midline. And this is one of the things that I warn patients about, is that they point straight down, and it turns out what big vessel that pulsates is right there. That's the aorta. So I've had trainees measure the aorta very successfully. It doesn't vary much with the respiratory cycle, by the way. So make sure that when you're looking down, you're actually going to tilt towards this direction so that you actually get the IVC. One of the things that I use, or I ask people to confirm that they've got the IVC, is if they can track the hepatic veins in the liver and show me the right atrium. So ideally, you can see the edge of the right atrium on your screen, and you've positioned your probe almost exactly perpendicular to the IVC right here. And that's important, because if you're going to measure in M mode, if you measure the IVC at an angle, the measurements are going to be off, right? You're going to have what I think they call that a parallax error. I'd have to think about that a little bit more, but we're going to switch to M mode. We're going to look at the motion. So in M mode, remember that this is a longitudinal with the cardiac cycle down here, right? This is a longitudinal view, and we're looking for the IVC. This is the edge of the IVC over time. This is when you ask the patient to take a sniff, and you can see that the IVC here collapses. Ideally, you're going to measure the minimum and the maximum during the respiratory cycle. So when I'm having very young people do this, I ask them, were you able to get the right view? What was the maximum size that you measured? I will warn you that in mechanically ventilated patients, there can be pretty poor correlation. If the patient's spontaneously breathing, this table right here shows up on your ultrasound boards, your critical care ultrasound boards. So you need to know this table cold. It's worth at least 3 or 4 questions, I can guarantee, right off this table. So if your diameter is less than 2.1 and it collapses, right, that is indicative or predictive of a very low CVP. Whereas if the IVC is greater than 2.1 centimeters and does not collapse, and we would call that plethoric, and is potentially predictive of a higher CVP. The intermediate zone is the zone of no man's land and is not predictive in that zone. Okay. Now, if your patient's unable to sniff, and the decrease here is less than 20%, that may suggest an elevated pressure. It's harder to predict that. Other signs that you would use from those views that we just talked about would be that dilated right atrium or an interatrial septal bulge. Those would be things that you would have already seen on your screen. Now, I will say I've added these are the numbers that are predicted. Couple warnings here, actually. Let's just talk about how you calculate this collapsibility. So these are the formulas here that are important. If you're using your maximum minus your min over the min or the average of the two, and use that to predict the percent collapsibility. In mechanically ventilated patients, you have to be aware of whether or not the plateau pressure is greater than 27, because that has been shown to affect the numbers. And then the other thing you have to be aware of is if the patient has intra-abdominal elevated pressures, right? So higher thorax pressures or higher abdominal pressures, obviously, are going to throw all the numbers off. In a spontaneously breathing patient, if you use this min number and it collapses by more than 18%, it has a sensitivity of 90% and specificity of 90%. That was shown by Barbier in 2004. If you use it over the average, it has to be greater than 12% and has a positive predictive value of 93%. I will say that I think that this is a little bit easier to get a gestalt for. You can kind of see the extremes even without doing the measurements, and maybe more reliable from moment to moment in the same patient during resuscitation, but you do have to be aware of these issues that are shown here. One number that you may see reported or may see SVC collapsibility, sometimes measured by TEE at the level of the pulmonary artery. If that collapses by more than 36%, that's predictive of responsiveness. That's probably most useful in cardiac surgery patients intraoperatively. I do want to warn you, so in many of the ultrasound texts that I look at, this is incorrectly reported as max, and that's obviously going to change that number. This is the original paper. If you need to reference it and go back and to find that it's actually the delta, the diameter at the minimum. So I want you to know that that's why I put that in there, is so that when you're looking in your textbooks, if you see that there's a difference there, sometimes it's incorrectly recorded. So let's just go back. We're going to summarize. The diameter of the IVC is actually just a static number. So if you just measure that and it says 2.1, that number is static. It is not very well accepted. Heisel, the same author that I just mentioned to you back here, demonstrated that in a couple of papers that it's really not predictive of volume status. So I would not recommend just using the diameter alone. You decide to use collapsibility, it is somewhat more dynamic. You have to be aware whether the patient's mechanically vented, spontaneously breathing. There are multiple validated indices as long as you know what they are. There are couple things that you might need to be aware of. This one's burned us last week. So I had somebody measure this and try to tell me, oh, yeah. The problem was that the patient had severe COPD. And so the entire IVC, and even it seemed like some of the aorta might have been extra thoracic. It was harder to see things. And some of the IVC, it was harder to actually see the IVC because instead of being behind the liver, it was actually kind of pushed down lower into the abdomen. There was a lot of bowel in the way. So be aware of that and be aware of abdominal wound dressings. Not always an easy thing to measure, but pretty reliable. Okay, let's talk about now, this last thing that I want to talk about is stroke volume variation, and this is where I'm going to spend the last of the time during talking with you today. And that's because this is a little bit about what we were interested about and what led us to the study that we did last year. So one of the things that we've noticed in the ICU is that our nurses are not big fans of non-invasive cardiac output measurements, for instance, CHEETAH. And that's because when we do the non-invasive measurements, it seems to not at all be predictive at all what the patient's volume responsiveness is going to be. And so knowing that, I think that that's helpful to kind of remember that that's only one piece of information, just as CVP is only one piece of information, even as ultrasound is only one piece of information unless you use it longitudinally. So this is a great paper from pardon me, almost a decade ago, demonstrating that it's not reliable. The manufacturers and some folks have demonstrated it to be reliable. And I bring this up just to point out that there is some question about how useful or what the utility of it is. So let's talk a little bit about how we could actually measure stroke volume using ultrasound. And we talked a little bit about this view. This was the parasternal long axis view. So this is the left ventricle here, and you can look through the aortic valve, and this is the left ventricular outflow, or left ventricular outflow track. And this is, if you measure the aortic valve here at the diameter, you can get the diameter of the aortic valve. We're going to use some fancy math to determine what the area is of that valve. And then you can measure what flow, so the velocity over time, what kind of flow goes through that area over a given period of cycle time. And so you can use math then to determine if the area times that velocity time integral should predict your stroke volume. And you're going to get that velocity time integral by doing that 5-chamber view that I mentioned to you, where you put your pulse wave Doppler in the aortic valve here. And so this will be the report that you get will be essentially, and you'll see there may be a little bit of aliasing here, but you'll see essentially the velocity report output here. So I mentioned to you that this apical 5-chamber view can be a little bit challenging for folks. It can be a little bit harder for us to get this information. Sometimes, especially in our trauma patients, there will be a pneumothorax that makes some of those cardiac views harder. So we really wanted to think, was there an easier way for us to take these measurements, right? Can we get an area of a vessel and a velocity time integral to actually calculate the stroke volume from some other vessel in the body? And so we said, well, what about the carotids? Works great as long as there's not a C-collar in place. So we did have a couple of those challenges, but for the majority of our patients, we're actually able to clear the C-collar pretty quickly. So we decided we were going to look at the carotid artery. There are multiple studies demonstrating this. Let's talk about just how we do that real quick. You're going to use a linear probe. You're going to have the patient supine with the head of bed at 45 degrees, their legs flat. In the vascular access mode, you're going to use your pulse wave Doppler, or in the using the vascular access probe, you're going to use your pulse wave Doppler mode and put that Doppler gate at a 45 to 60 degree angle. And I'll show you that in just a second. You're going to monitor it for several cycles. Now, I'm going to explain to you a little bit about how we did our study differently and why we did it. But let me just show you real quick. This is how the view will typically look. So this is your carotid artery in the longitudinal direction, right? This is your spectral gate right here. It's a little bit hard to see because it's a light gray on a light gray screen, right? But you're going to put your gate, you want that gate at a specific angle so that you actually get a reliable measurement, and then you're going to look at your peak velocity. So one thing I want you to notice here is that there actually may be a variation based on the respiratory cycle. So that's important for you to remember. The other thing that's important is that this peak velocity and the velocity time integral could change if you gave a fluid bolus, or it could change if you did a passive leg raise. So you could do a dynamic study by just looking at the this location and see how the heart responds and if there's an increase in stroke volume from this location. So this is one of the first studies. It's from almost about a decade ago, published in Chest, demonstrating, so they study whether carotid Doppler VTI, whether the stroke volume predicted by the carotid could compare to a typical bioreactance monitor. So they actually, I think, used the cheetah in this case. So it was done in Eastern Virginia Medical School. So they used the delta SVI from the cheetah after passive leg raise and compared it to the delta SVI after a bolus. And they then used that. They did carotid measurements in both settings. You'll see that the interesting thing here is that the change in carotid blood flow was the only thing that was significantly different between fluid responders and non-responders in this patient population. Now, tidal volumes here were about 6 to 8 cc's per kilo. They did not find that the cheetah was very predictive, and they did suspect that might have been a tidal volume issue. Let's talk a little bit about one more study that I wanted to show you. So this is that respirophasic peak velocity variation. So I was just marched that out for you on the diagram that I just showed you. So if that peak velocity varies as associated with the respiratory cycle, that can be predictive of fluid responsiveness in patients. These were 40 CABG patients who they defined responders as having a delta SVI greater than 15%, not 15% after volume expansion. And then they found that the patients who were responders to fluid actually had that respiratory variation. And it was actually fairly predictive that delta V peak, so that's the change in the in the cycle from the maximum to the minimum, over the respiratory cycle was actually better predictive than the static indices of volume responsiveness. So that respirophasic change and the actual change in numbers is important. Now, I think that this change right here, I think that this measurement is easier to eyeball than I think it is for us to actually calculate the VTI and do the measurements. There are a couple caveats I want to share with you, and there's a reason why. So let me share. This is one more study. I included this just so you have it. This is the Korean group, actually. They have actually done a couple of different studies that you can see that demonstrated that these carotid ultrasound measurements were fairly predictable. This was in spontaneously breathing patients, and they demonstrated that variation in the peak velocity, and that it was fairly predictive. This is the area under the curve, and so you'll see that this is the corrected flow time curve, and then this is the change in peak velocity curve. And so both were fairly predictive here. I'm going to show you one more study that I kind of wanted to give you. This is another caveat. So this is also carotid blood flow in children has also been demonstrated. So this is, I think, about 5 years old, if I remember correctly. This I think, this one was just published this year. And what was interesting was that if you took the entire VTI, so the total VTI, it was not as predictive. But if you use the systolic VTI, it was a better predictive of fluid responsiveness. So So that's just something to keep in mind. Again, there can be slight variations in what's most predictive based on how your patient, like whether your patient is ventilated, whether it's a kid, whether it's whether you're using respirophasic changes or not. But I think the visual is probably, I think the respirophasic variation is probably the most easy for a novice person to pick up. Finding the carotid is not hard. Staying on the carotid while you're moving the patient into a passive leg raise can be a little bit more challenging. Now, the one warning about this, as I just said, it can be hard, a little bit hard for a novice. So I'm not going to be inaccurate and say that this is a perfect way. I will say that there are a couple studies, and I've listed them here, that say that carotid Doppler is not reliable. I think one of the things that you have to be careful when you look at these studies is that a lot of them use novice physicians who haven't been doing ultrasound. This was one of the challenges that we ran into with our study. In hindsight, I think there probably is a big limitation for us in terms of the data that we came up with, because if you're not used to doing these numbers, if you can't accurately get them, unlike Massey, it may not be as predictive in the novice's hands. So a couple things that I wanted to just show you. These are kind of cool. Just file these away for your information. Is that this is a patch that you can put on the carotid artery that measures this wave flow. You leave it on the carotid artery and it reports out the cycle, so you can see that there's no change in the VTI until you do the passive leg raise, and that it's similar to what measurements they were able to achieve using the VTI across the aortic valve. So I thought that was pretty cool. Pardon me, this is a follow-up study from this year, actually just published this summer, that showed that it was actually the receiver rate of curve was very high for the change in the VTI, or change in this, whatever metric it was that they were measuring, whether it was the flow time. So a couple studies have demonstrated that flow time is more predictive. Some have demonstrated that VTI is more predictive. So I just thought it was interesting. I wanted you guys to see this, that this patch may become part of our future. Since a novice can't do it, maybe if you can just put the patch on and it gets the right information, that'll do it. The last study that I wanted to show you, and this will be the last piece of information to tuck away, is that one study actually looked at the brachial artery. This was a proof of concept that measuring the brachial artery peak velocity. Some people have brought up the issue, well, the carotid bulb may change the flow. What if there's carotid stenosis? That's also a limitation of being able to measure the peak velocity at the carotid, or the VTI at the carotid. So that may affect the numbers and the reliability of the study. So this group actually measured the brachial artery. And this was a prospective study using more than 62 patients. It was all healthy people. They put them in sitting upright to get the baseline, and then put them in passive leg raise. So they just got the advantage of the passive leg raise. Pardon me. And then they identified them as responders if there was, if the stroke volume increased by more than 15% after they got, step 3 was that they put them back and then they gave them a bolus. And if they responded to this bolus, they defined them as responder. So then they went back and said, well, how did they respond here? Was the passive leg raise reliable? So those patients who had a change with volume expansion correlated with the change in velocity, the peak velocity, by passive leg raise. So this is easier because 1, you don't have to calculate the VTI. 2, you can just use the peak velocity. 3, it's in the brachial artery, which doesn't move around as much, and it's not as hard to slide off the neck there. This just a change in peak velocity of 10% was predictive of fluid responsiveness in this patient population. So I would like to file this away. One thing that you need to know is that these patients were, some of them were on vasopressors. So vasopressors do not seem to limit the ability to use these peripheral vessels for this method. So blood flows are dynamic studies. The carotid artery is actually pretty predictive at both the change in peak velocity, variation with respiration. I showed you a study about using the corrected flow time. I would say that there's a little bit of caution using this, that you might need some experience to use it reliably. The brachial artery is promising, and they may have a device for you to use. I'm going to skip over this because I just want to point out one of the things that we did as part of our study was we studied how we evaluated folks. And so there was a QI process involved, and we used validated measures to decide how well our folks learned the methods, and which is where I get the information about what was reliable and what was not. So some POCUS methods are reliable for the novice. MAPC, right ventricular, left ventricular size, a little bit of collapsibility. We still need some work on the carotid blood flow measurements. Thank you guys so much for the time. I didn't want to keep you longer than necessary. I take any questions if anybody has them, or I will meet you in the SICU shortly.